We are going to invite Dr. Maurice to talk about endemic African Kaposi sarcoma, presenting with pathological fracture of the left tibia and fibula.
Well, that's the title as advertised. That's my name, my affiliation. University of Calabar, honorary consultant with the teaching hospital. That's one roundabout that will welcome you when you come into Calabar, the city. And I have shown this picture to highlight that Calabar environment is just one of the remnants of the southeastern equatorial rainforest. Now, Kaposi sarcoma, first described by Moritz Kaposi, a Hungarian dermatologist, in the year 1827. The first case, this was mainly in those in the Eastern Europe and the Mediterranean. But the first case of African Kaposi sarcoma was described in West Africa in 1914. The second case was reported in Cameroon in 1922, and we share the same border with Cameroon in the same equatorial belts. Now, endemic, it has been endemic in Africa before the advent of human immunodeficiency virus. There are 4 clinical variants. The classic, otherwise called the Mediterranean, the endemic or the African. Then the immunosuppression or transplant associated, and then the one that has been described, the acquired immunodeficiency syndrome, AIDS. The important thing to be highlighted here is that out of the 4 variants, the histopathological picture will be the same. So you cannot really use histology to differentiate. You have to use history and laboratory investigations. Now, Taylor et al. In 1971 in Uganda described 4 clinical types: the nodular, the florid, which is also divided into 2, the type 1, which is the exuberant granulation tissue, and the type 2, which is just the swelling with the skin intact, the infiltrative, and then the lymphadenopathy. He also went ahead and described 3 variants that behave differently to chemotherapy and prognosis. We'll see the typical picture of our patients. The type 1 is the mixed type, where you find the spindle cell and the blood channels. And the type 2 that is described as monomorphic, we have only the spindle cells, and then the blood channels are not there. And then the type 3, which is anaplastic, which is the aggressive variety. It presents mainly as cutaneous lesions. It could occur in other areas, but majority of them will present as cutaneous lesions. Musculoskeletal involvement is uncommon in these patients. And when they do occur, they are secondary to local extensions from the skin lesion. Well, the objective of this study was to report the case of a locally aggressive Kaposi that presented with pathological fracture of the left tibia and fibula. And also we had a dystrophic calcification of the muscle, the adjoining muscles. We'll also highlight the poor response to chemotherapy. Most of the type 1 cases do well with chemotherapy, but this particular patient did not behave in that pattern. A 52-year-old male farmer who presented with pain and inability to walk properly with the left lower limb of 2 months. This patient had these lesions, started as multiple nodules. Some were ulcerated at presentation, and it progressed from the left foot, to the lower part of the left leg. So the peculiarity of our own patient is that they present very late. It was only when he developed a fracture and had pain, despite the florid lesion, despite the cutaneous lesions, that was when he presented. There was no previous history of trauma, chronic cough or difficulty in breathing. The patient at presentation had good appetite, admitted to loss of weight. There was no passage of blood in stool, no history suggestive of immunosuppression. And as expected in our environment, most patients come late. They will first present to the tradomedical healer, and he had been exposed to topical and oral herbal medications with no improvement. That's the typical picture and presentation. You could see the nodules, see the level of lymphedema when compared, the hyperpigmentation, some bit of ulceration. This second picture is to highlight this area that you see. There is a slight deformity in the lower tail where the patient had a fracture. Those are the nodules, ulcerated. Now, on examination, he was chronically ill-looking, febrile, pale, and anicteric. He had a unilateral left non-pitting edema and a left groin lymphadenopathy. Examination of the chest and abdomen were unremarkable. We had hyperpigmented patches and multiple nodules that ranged from 0.5 to 2.5 centimeters, some ulcerated as we saw earlier. He had a non-tender multiple firm discrete mobile left groin lymphadenopathy. One significant thing was a low PCV at presentation. The white cells appeared normal and platelets, and the erythrocyte sedimentation rate was 112 millimeter per hour. A retroviral study for HIV, both serology 1 and 2, was negative in this patient, so our patient was not of that subtype. The X-ray of the foot or leg revealed a soft tissue swelling, we'll get to that later, and a lytic destruction of the distal tibia with a pathological fracture of the tibia and fibula. Then the adjoining area, the soft tissue, the muscle, showed an ill-defined stippled soft tissue calcification adjacent to the area where there was a lytic destruction of the bone. That's this patient's typical picture at presentation. You could see the lesion at the lower tail. The next presentation is to highlight this calcification, which was in the muscle, a dystrophic calcification adjacent to the area of the fracture. Then an incision biopsy of the foot nodule showed the multiple foci of circumscribed nodules of mesenchymal tumor. It was composed of squamous cell enclosing vascular channels, and the diagnosis was Kaposi sarcoma. A biopsy of the groin node just revealed a reactive hyperplasia due to probably the infection from the ulcerated lesions. That's a low power photograph showing the spindle cells and the vascular channel. It's a higher power. Those are the spindle cells and the vascular channels. So made a diagnosis of an advanced locally aggressive endemic Kaposi with a pathological left tibia, fracture of a left tibia and fibula. And typical in this patient, the adjoining muscles was also affected and infiltrated by this tumor, and then predisposed and set a stage for a dystrophic calcification. The bone was destroyed at one end, and then we also had calcium being deposited in the muscle. It's not something that we find often in this patient. And to prove that it was dystrophic calcification, the patient had a normal level of calcium in the body. It wasn't arising from a high level of calcium. Well, he had iron dextran. We tried to build up his packed cell volume. We chose Vincristine and Epirubicin that was available in our center. This patient initially declined radiotherapy. In Nigeria, not all the centers have facilities for radiotherapy. And if you have to travel several hours to other centers, the problem of relocating finance was difficult. That was offered to him because it would be good because of a locally advanced lesion, but he declined that. We may still have to visit that option for him. And he was mobilized on non-weight bearing of the lower limb. The outcome really was a stable disease in terms of the cutaneous lesions because we did not notice progression, development of new, nor was he actually having a regression in the other lesions. In the skeletal X-ray, the skeletal lesion did not show any evidence of healing despite all this duration of therapy. Now, Kaposi sarcoma is a neoplasm of multifocal origin, that is, can occur from undifferentiated spindle-shaped vasoformative cell. Majority of the patients will present with cutaneous lesions. Etiology is believed to be multifocal. When we look at the genetic component, we've had the prevalence very high in some ethnic groups, in the Jews, Italian, and etc. The immunologic associated with HIV, it's proven, and in our environment, we are finding it commoner. We used to have 80% of the endemic and 20% of HIV, but now it's the reverse, 80% of the HIV and 20%. I think is an indication of the level of control of the infection, which is really not good. Then the infective component, we're all familiar with the human herpes virus. We rarely find that association with most of our patients. And then the environmental. It is believed to be common in the equatorial sub-Africa. There have been a lot of theories, like people move around who are mainly farmers, contact with certain components of things in the soil, and so on and so forth. Kaposi now is most frequently reported malignant dermatological tumors in some areas of Africa. When we put together one of my papers, we found out that Kaposi, it used to be squamous cell carcinoma. In sub-Saharan Africa, the commonest skin cancer is squamous cell carcinoma as opposed to basal cell that we find in the Caucasians. And then the second used to be Kaposi, but now studies have shown that the Kaposi is taken first position and squamous cell second position. This lesion, we want to recall, was endemic in Africa even before the advent of HIV. So we have sufficient evidence that in the endemic or the African type is not really related to HIV infection. The African type found primarily in regions of equatorial South Africa. I showed you what was left of Calabar and the rest in that belt. It's quite common. It accounted for 9% of malignancies in Eastern Zaire. In Calabar Center, it accounted for 38% of skin malignancy. The endemic African Kaposi runs a variable clinical course. So we see a wide spectrum and it's beginning to stimulate our thoughts. Are we really dealing with one disease, or we have a spectrum of diseases that will behave in different ways? It can range from minimal to florid cutaneous lesions. We recorded a florid lesion in our own center. Despite the size of it, it responded very well to chemotherapy. So a lot of them, a subset, will respond to chemotherapy. Now, disseminated endemic Kaposi in a young man without evidence of. So we are having a mixture. The disseminated disease, naturally, we expect should be with the HIV associated. But we found the endemic also exhibiting this, which you investigate this patient and you cannot find any evidence of immunosuppression in them. And atypical and widespread lesions are commoner in the HIV. Some food lesions, until you biopsy them, they may still be Kaposi in our environment. Typically, majority of the patients, 90%, will affect the lower limbs, like we had in this case. Now, Kaposi sarcoma of the bone and skeletal muscle is unusual. Hence, the presentation of this case. The first case I'm describing, presenting with a pathological fracture in a HIV-negative patient. Now, disseminated bone lesions in AIDS-related Kaposi has also been reported, and when it does come, they come with very poor prognosis. Now, we have presented this patient to highlight a locally aggressive and infiltrative cutaneous lesion with musculoskeletal disease. Haddo et al., 2013, had also reported Kaposi sarcoma infiltrating skeletal muscle, but not with a pathological fracture. Now, in the author setting, pathological fracture of the tibia and fibula had been reported following cutaneous squamous cell carcinoma. We've had two cases, squamous cell carcinoma of the skin, neglected lesion, then pathological fracture. This is the first case that we're reporting with Kaposi sarcoma. We've seen that slide before. Very peculiar. Around the bone, there's a destruction, and then calcium is now deposited with the adjoining area where the muscle tissue is. Now, there are various radiological types, the cystic, pressure necrosis from uniform rarefaction, and complete bone destruction and pathological fracture that we have. If they do come early, reports have shown that those that the periosteum still remain intact, with successful chemotherapy, you could have healing in the bone. But we just wonder, and we're not surprised in our particular patients where there was complete bone destruction and a fracture. And despite the chemotherapy, there has been no improvement with that. Now, the outcome is evaluated according to the RECIST guidelines. And in our patient, we fell under the category of a stable disease, no new lesion or progressive lesion. And then there is a poor response to chemotherapy because we had a type 1 lesion in our patient. And the tumor is known to be radiosensitive, useful for local radiotherapy. Radiotherapy, like I had highlighted, is not available. And our patient had declined that option because of the distance of having to relocate to travel and then the cost involved. So in summary, we present this advanced, locally aggressive cutaneous lesion in a HIV negative patient. We present a patient with Kaposi sarcoma with a pathological fracture and a musculoskeletal, with a muscular disease and steeple classification in the adjoining soft tissue. We present a patient with poor response despite the type 1 histology that the patient had. Now, Kaposi sarcoma, if neglected, presents with significant morbidity. Ignorance, sociocultural factors, and poverty were underlying factors in this patient, and indeed underlying factors in quite a good number of patients we find in sub-Saharan Africa. Health education on early presentation, early diagnosis will indeed really improve outcome. And I believe that further research is required in tumor biology to be able to unravel why some type 1 lesions, chemoresistance with poor prognosis, and others. So what I'm saying, or what we are saying, is that histological type alone may not be used to predict the outcome in patients. I want to thank you. Yes.
Any question to Dr. Maurice?
Thank you, Doctor, for your nice presentation. I want to ask you a question regarding the pathological fractures. Those types of fractures, we have nothing to do with that fractures. Is there any orthopedic consultation to try to heal this lesion as much as we can? although the causative factor is present.
Yeah.
So is there any contact with the orthopedic surgeon?
This patient, ideally, we consulted the orthopedic surgeon. And without the experience that we had, usually when you put them on chemotherapy and immobilize the limbs, they do well, and you find bone regenerating. Now that we have this failure, we are back to them to try and see if they could stabilize the fracture while we look for other avenues of. So it's a multidisciplinary approach when you have circumstances like this. But from previous experience, there are not so many cases. You don't go ahead to intervene surgically. If they do respond to chemotherapy and you have the bone forming, we leave them alone.
At least they put the casting or directing the bone together, so the healing of process will have in place if there is chemotherapy treatment.
Definitely, that's the next option now that chemotherapy is not really working. We want to put an implant to stabilize, then we send the patient for radiotherapy. I think he will do well if we take the option of radiotherapy. Like most pathological fractures, surgical intervention is the best approach to it, alongside with other investigation.
Thank you very much.